pleased to be here, and I was telling Steve that I agreed to, or actually volunteered to come and talk to your group when we first met shortly after I came. At that time, it seemed like a good idea, but last night when I was putting together this talk, it didn't seem like it was such a smart idea because, you know, I have lots of things that I talk about to medical students and residents and other colleagues that have to do with infectious disease diagnosis and treatment. And then there are talks that I give that have to do with my research, which are really molecular virology. And so I wasn't sure exactly who I would be talking to here and what would be of interest to you. So I tried to put together a talk that just touches on some aspects of how infectious diseases affect public health that you may not have been aware of, that you may not have thought of, despite the fact that you do think about infectious diseases, which are obviously such a big problem particularly in other parts of the world. So how many people here are students? So if I ask you what are infectious disease problems in public health, what comes to mind as the biggest infectious disease problems worldwide? There isn't one right answer. Malaria? HIV? Okay. What else? So malaria, HIV, tuberculosis. There we go. So that probably kills more people than anything else. What else? That's the other big thing. And what about, I'm just curious, what about in this country? What do you think infectious kills people? It's age dependent, of course, but the pneumonia is a lot of it, especially in the elderly. So these are all the things these are many of the things that people talk about. I'm just curious, what about non-infectious? What are a couple of the big ones that are non-infectious that cause the mortality? Heart disease and trauma, particularly vehicular trauma. And in the rest of the world, it's not guns like it is in the U.S., which is still a major cause of mortality, especially among the young. But I'm going to talk to you about something else than all these things that we just mentioned. So I'm going to first talk about one of the biggest successes in public health, and where I think you really have success in this country, not just in mortality but in morbidity, and this is one of them. And shortly after I came here, I went to a talk. I don't remember who it was. It was one of these guys who's written a book about vaccination. He wasn't a physician or really any kind of healthcare professional. I think he was a journalist, really. But it was a very good book, and he talked. But he gave us one of the examples of things that don't really kill people or aren't really that serious as chickenpox. And I went, oh, my God. And I went up and talked to him, and I said, do you realize that kids die from chickenpox? He goes, no, what? Are you kidding? And this guy had written a book about it. So actually, even physicians aren't aware that chickenpox does kill children. And it's not many, but, if it's your kid, I think you'd probably think it was a pretty important thing. And so, because there were millions of cases of chickenpox, there were at least 100 deaths a year prior to universal vaccination. And there was a lot of controversy about this vaccination because the justification ultimately that was made to license it and have it paid for was that it would not even decrease morbidity, but actually decrease cost to society in terms of time off from school and work. And that actually is a significant cost. Okay, so I mean, if you add everything up like a actuary, a lot of time off from work or lost income does lead to morbidity and mortality because you lose your job, then you start. So all these things are tied together. So just because somebody says, well, chickenpox vaccination didn't really, save that many lives, well, it actually probably does, relieve a lot of social cost in this country. So the risk of death from chickenpox is also higher in adults. So if you manage to make it through to adulthood and then get chickenpox, for example, when you're pregnant, your mortality rate is quite high. And it used to be even higher before we had antiviral therapy. And after the really in '94, when the vaccination program was started, there was again there were a lot of unknowns about how effective this would be and what the effects would be. And the 2-dose vaccine was instituted when it became clear that not everybody responded fully and that you might get longer durable immunity if you had a 2-dose regimen. What they've now seen is in the last few years there have been some years where not one single person in the United States has died from chickenpox. Okay, and it's really a remarkable change. And so if you look at these, you can see that since the advent of vaccination in '94, not only has the number of deaths gone down to almost zero, but the only people who actually have died from, or even secondarily attributed to varicella, are the elderly, and these are probably immunocompromised people. So the epidemiology of varicella is that it's transmitted by the respiratory route. And you can imagine in areas where there's malnutrition, chickenpox probably kills a lot more than the relatively low death rate in this country. So in the tropics, where it is more common in the adults also, it's probably not really very well documented what the death rate is. But if there could be universal vaccination, this is yet another way in which globally deaths from pneumonia and sepsis could be decreased. Now the other thing that I was just going to show you is that zoster, which people again think of as not particularly shingles, as not particularly serious, can be very, very problematic in the elderly. Zoster is caused by reactivation of chickenpox, which is latent. And it actually occurs in a surprisingly large number of people over the age of 60. And the age just starts rising once you get over 50. Now, like I said, it enters via the respiratory tract, and actually it's a systemic illness, and you have seeding of the nervous system, which is where it establishes latency. And this is why you get shingles and reactivation. And this is the classic let's see, just turn the front down. Yeah. So this is the classic dewdrop on a rose petal, which is a very poetic description of a not so pretty lesion. But that's a classic herpetic lesion, whether it's varicella, zoster, or other herpes viruses. And you get it on the face, and it spreads outwards. So the little kids, you'll see the lesions there, and they evolve. So they evolve into pustules. And it's funny, everybody knew what chickenpox looked like, and nowadays physicians really don't. And there was a report in the news recently about how somebody had measles, and nobody knew what it was because none of the physicians had ever seen it, and it took them several days to make the diagnosis, whereas in the past it would have been made at the time they walked in the door. So this shows you that there are, I don't know how well you can see this, but there are lesions in all different stages, and that's the thing about chickenpox, is that you get this viremia where the virus causes lesions, and they come in waves, so that you get, that's another characteristic, is that you'll have new lesions and old lesions that are healing. And I don't know if you can see this very well. I can see it on there, but there's a rash that is in this sort of band-like distribution, and this is the distribution of one of the sensory nerves, and this is how it reactivates. And so you'll get, when you get shingles, you get it in this band-like pattern that corresponds to the distribution of the nerves. And I apologize to those of you who aren't used to seeing things like this before breakfast, but this is the distribution of the first branch of the trigeminal nerve. And the reason I showed you these sort of sensational pictures is just to remind you that I think of the importance of vaccination more than anything else as it relates to public health, because this is preventable. And this is the kind of thing that has actually led to the, not directly, but to the complete loss of function of an elderly patient and their early demise. There was a lady that a friend of mine was telling me that he took care of, and she was, I think 65, 70. She was playing tennis, had a very active social life, developed this trigeminal zoster, facial ophthalmic zoster. And the problem is, even after it heals, you can be left with debilitating pain, this neuralgic pain. And so every time she would go out and the wind hit her face, it would stimulate an attack of this neuralgic pain to the point where she could no longer play tennis. And then she stopped exercising, became kind of housebound, and eventually ended up in a nursing home. And it was he attributed it all to the fact that she got zoster. So there's a zoster vaccine, okay, which is recommended after you're 50. And these are various distributions of the trigeminal nerve. And this is essentially preventable with vaccination. So you get the vaccine when you're 50, and it's basically just to boost your natural immunity. And this shows you the sort of sequelae of nerve damage that can occur. So this is actually a success story of universal vaccination, at least in this country. And we can talk about, when I'm done, about some of the issues that have to do with this type of vaccination and some unique problems that it actually might give rise to. This is disseminated zoster, and again, the problem of chickenpox in immunocompromised patients is that it can kill you. You get visceral dissemination, and this is the kind of illness that, again, usually from reactivation, but primary infection in children who have never been exposed, that can be lethal. So if you have a universally vaccinated population, the herd immunity helps protect all the immunosuppressed people in our population. And this is so important, not just in developing nations, but in areas where, like in this country, where universal vaccination has stopped occurring essentially because of societal factors, which we can talk about as well. So one of the other things I was going to talk about as it relates to public health is that that it can be mistaken for things, especially things that may be employed in bioterrorism. So I always tell the clinicians that you're not going to know that you're the first person to see something, right? It's only in retrospect that it's recognized. And so you have to sort of remember that this may not be chickenpox. There's, as we know, smallpox in the wild has been eradicated by vaccination, but there are stocks of smallpox that hasn't been. They haven't all been destroyed, and that's a possible bioterrorism agent. And this is a kid who doesn't have chickenpox, but rather this is primary herpes simplex infection. And despite how bad it looks, this kind of thing actually heals without a problem. It's just because the immune system is so immature. And this is somebody who has eczema. You don't usually see it this bad anymore because we have some antiviral drugs, but this person has had disseminated cutaneous infection with herpes simplex virus. So this is really for clinicians, but we can tell the difference between smallpox and chickenpox clinically, or at least we have the possibility of telling. So I'm going to see how good Scott Benson's memory is. Which of these two viruses is varicella zoster, Scott? Gosh, it's a good thing you went into public health. Varicella is on the right. This is the typical herpes virus with the electron microscopic appearance of the DNA core and a capsid, and then a tegument, and then the outer envelope. This is varicella. This is smallpox or vaccinia. This is a pox virus. Okay, and pox viruses are huge viruses that that are box-shaped. And that they're completely different families, even though they both cause cutaneous eruptions. And this is a historical picture of a kid with smallpox, and you can see that actually there is extensive involvement throughout. And there's a difference to the lesions here. These are deep-seated, and that's why they scar. So if you've seen people, you may have seen people still around in India and Africa who have had natural smallpox, and it causes pitting and scarring. So smallpox actually can be spread not only by droplets, but also by contact with lesions and by fomites, which are inanimate objects that have been contaminated. And they, so that leads to the infamous stories of the original use of smallpox as a agent of warfare, which is because the blankets that were given to Native Americans were actually contaminated with smallpox. And also, you could send small vaccine by just dipping wicks in vaccinia virus and then shipping it across to the United States, for example, and help to actually do universal vaccination because you could have fairly stable vaccines. So I put this up here just out of interest because I think the use of infectious diseases as bioterrorism agents is unfortunately a new part of public health, and Scott is smiling because I put this up here to show how complicated the world has become and how everything is global, right? So including infectious diseases. So the reason I put this up here is because this is how actually a particular pox virus got all the way here from Africa and actually caused disease in the United States. And this is a Gambian rat, which some people decided would be good to have as an exotic pet. So this was being kept in a pet store, and these are prairie dogs, and they were also being kept there. And of course, these don't come into contact except when you bring Gambian rats and put them in a pet store in the Midwest. Okay, and so somebody took these home and got monkeypox. Okay, and so the transmission chain was from Gambian rats to prairie dogs to Midwesterners, and there's some clinical differences, and we don't think it's quite as bad as smallpox, but it's a potential agent of it's like any disease that gets into a niche where it wasn't there before. It could really have unforeseen consequences, and there was a lot of spread, and the concern was that there would start to be perhaps person-to-person spread, because you can have fairly rapid selection, for those of you who believe in evolution, of viruses that can be selected to transmit from person to person, whereas before they couldn't. I mean, this is one of the big fears with influenza, is that viruses that are extremely lethal but are not selected to actually be easily transmitted from human to human, when they do jump that species barrier, when you get avian flu, the mortality is very high. And the worry is that avian flu, for example, will acquire the ability to be easily transmitted from human to human. And this just shows you that the monkeypox lesions are similar to smallpox. And there are various other types of vaccinia viruses, camelpox and so on, that are all, so this is one more thing for you to worry about when you go to Africa. So now I'm going to shift gears and talk about some infectious diseases that you may not have realized that are probably far more of a global problem and cause public health problems that you don't typically associate with an infection. And that is the infections that are related to cancer. So this is a typical case of a college student who has an acute febrile illness that is characterized by severe sore throat and lymph nodes. So who knows what this is likely to be? Somebody besides Scott. That's one very likely thing, which is strep throat. And the other is infectious mononucleosis, usually caused by EBV, but nowadays the differential includes acute HIV infection. So if you look, this is not a typical example of the severe exudative pharyngitis that you can get not only with strep throat but with mono. And it's often confused for strep throat, and people are given antibiotics, which can sometimes lead to a pretty severe rash. So epidemiology of EBV is very interesting because almost everybody has EBV infection. So you all are likely to be infected, especially those of us who are over the age of 25 or 30. So there are two waves of seroconversion. One is in early childhood, and the second is in late childhood or college age. So the reason for that is that the virus is transmitted by saliva, and there are two major times in your life when you trade saliva with your friends, and that's when you're in preschool and when you're in college. And so the incidence of infectious mononucleosis, though, is much higher when the infection occurs as a young adult. Okay, so mononucleosis is very uncommon in areas with large families, poor hygiene, lots of sharing of utensils, whatever. Okay, so it's a very epidemiologically affected illness. This relatively benign infectious mononucleosis, usually benign, and we don't really understand why people get mono when they get it as an adult as opposed to a child. So children don't really get sick with EBV. They might have a mild febrile illness similar to many of the other illnesses that they get as a child. But it's only when you get it as an adult that you get mono. And there have been lots of speculation about whether it's really that kissing is more likely to give you more virus, and it's really a different type of infection than when you just get a little bit from a spoon or something. But it probably really has to do with a difference in the immune response. And this is still an area of investigation, not just because it's an abstruse point, but because it has a lot of relevance to what the immune response to vaccination is, just in general. Why some people respond well to vaccines, why some people may not, and also, importantly, why people have bad reactions to vaccines. It may actually have to do with the fact that you are having cross-reactive responses to the vaccine, because as you get older, you've seen so many other things, and you have actually cross-reactive responses. Say, an epitope on flu actually makes you react to EBV differently than you would if you hadn't gotten to the age of 20 and been exposed to a lot of pathogens. And this really becomes important when we talk about why we're really interested in EBV, not so much because it causes mono, even though that can be a real problem. So like I said, it's more common in older patients, and usually all of this is controlled by a vigorous cell-mediated immune response, and complications are rare. And how do you get it? You get it from the virus entering through the throat, but it gets into the B cells that are circulating underneath the epithelium, and then it establishes latency and gets into the memory B cell compartment so that it can persist for the lifetime of the host. And every now and then it reactivates under certain stimuli, and you shed virus in your saliva to continue the cycle of infection. Now, in addition to mono, it's associated with a variety of malignancies, including Burkitt lymphoma in Africa particularly, and nasopharyngeal carcinoma. And these are the two big cancers that I'm going to briefly touch on. And it's also associated with Hodgkin's lymphoma, which is seen worldwide, and AIDS-related lymphomas, and lymphomas in immunosuppressed people. But in terms of the millions of people that it affects, in particular epidemiologic and public health issues, Burkitt lymphoma and nasopharyngeal carcinoma are, I think, the most important. Now, EBV was actually discovered because of the association with Burkitt's lymphoma. And I'll come back to this. So how does this virus that's present in virtually everyone cause cancer, especially in some populations? And why does it cause cancer? And this is still why we study these viruses. And one of the reasons is that that it's really an incidental consequence of the viral strategy to persist for the lifetime of the host. So it does that by a variety of mechanisms, and to evade the immune system and to keep the cells that it infects from getting killed off. So it's really very, very good at not causing a lot of problems and staying with you for the rest of your life. But those very same properties can be very detrimental and can lead to oncogenesis when the right cofactors and other conditions are present. And those, to some degree, are environmental and have to do with co-infections, particularly in the developing countries, and genetic factors. So this is a picture of Burkitt lymphoma in a young child, and this is actually a picture that Dennis Burkitt took. And Burkitt was a surgeon in Africa in the 50s and 60s, and he noticed that there was a tremendous incidence of this malignancy in children, and it's still in parts of Africa the #1 childhood cancer. And Burkitt's lymphoma is a very aggressive tumor, and it often involves the jaw and face of children. It's a rapidly growing tumor, and it can actually lead to death in those countries from malnutrition. It also affects visceral organs, but it's also quite responsive. And this is, even back, I don't know when this was, late 50s, early 60s. With rudimentary chemotherapy, he was able to cure some of these children. But he noticed that, and these are some X-rays. Look at the dental anarchy, as it's called, just complete rapid growth that disrupts all the facial planes, and it's a terrible tumor. And you can imagine in relatively primitive conditions what kinds of effects this type of malignancy can have. So Burkitt actually noticed that this was very geographically demarcated in Africa. And the name, the sort of Burkitt lymphoma belt has been coined because even today you see this even locally, you see very different patterns of incidence where you have some areas of very high pockets of high incidence and low incidence. And these correlate with several factors: temperature, rainfall, and altitude, in addition to geography. So this is all sort of equatorial sub-Saharan Africa. And the coincidence with malaria was noted by Burkitt, and Burkitt actually thought this disease was spread by mosquitoes or by some other insect. So he really thought it was an arbovirus cancer, and he talked about this and gave a lecture when he was in England. And Anthony Epstein was in the audience, and he spoke to Burkitt and arranged to have some of these tumor samples flown from Africa to London. And then he looked at it with the electron microscope, which was just available, and very shortly after looking at it, he saw what looked like those herpes virus particles that I showed you of chickenpox in the sample, in the fluid surrounding the sample, and that's when the association with the virus was first made. And it was subsequent to that a lot of the research was done that showed how it was related. So this is actually a map, and you can see here how it's very it's very demarcated. So there's really no Burkitt up here at all, and there's very little down here. And there's some interesting stories about how, and I can't remember which island it was. But there's an island where, after they wiped out malaria, Burkitt incidence went away. Okay, so there's always been, and I'll come back and talk about this. And these are the areas where there's nasopharyngeal carcinoma associated with EBV. And there's also, if you actually look, there's Burkitt's here going across, and also in Indonesia. So this is a picture of a biopsy of Burkitt lymphoma, and the cells that are all round and growing very rapidly. Now, you may ask, why is he talking about this stuff? But it's important, and to understand what the relationship is with malaria, and why there might be a relationship with malaria. So, the classic feature of Burkitt's lymphoma is that there is a chromosomal translocation event. Okay, so all the Burkitt tumors that you see have this chromosomal translocation, where an oncogene has been moved and upregulated by the translocation. So but that happens whether you have EBV or not. So you can get EBV negative Burkitt lymphoma. Okay, so that's a sort of fundamental lesion in the tumor. But EBV is a cofactor for this. And if you look at the endemic, that is the African Burkitts, it's greater than 90% EBV positive. And that's not the case with the Burkitt lymphoma you see in this country, or where in the non-endemic forms. So there's a real association with malaria and EBV, but only with that type of, particularly of the childhood cancer. So how do we explain all this? Well, we don't really. We still don't really have a really good answer. But for a long time, it was thought that this is because EBV is fundamentally a oncogenic virus. Okay, and the reason it was thought that is because EBV has the unique property. If you take the virus, if you take isolated virus, we take some B cells from you or me, and we infect them in the laboratory, it rapidly transforms them, immortalizes them, and they start growing in these clumps that you can see here. And this is actually from my lab. It's not from a textbook. So if you look at this, remember that picture I showed you of the Burkitt lymphoma? They actually don't look like this. These look even more abnormal than the real tumor cells. These are growing in clumps, and if you look carefully, they're all kind of misshapen, and they have little projections. So they're very highly activated. This is what a B cell looks like when it encounters the antigen and is really proliferating, okay, in a very activated way, and its gene expression has changed. But that's not what Burkitt looks like. Burkitt has a chromosomal change. These are not tumor cells, really. If we took this and put it back in my body, they would go away, actually, because the immune system would just get rid of them. And like I said, we all have EBV, and it occasionally does this kind of transformation, but the immune system controls it right away. So this idea that the virus is just driving these cells to proliferate and cause Burkitt's turns out to actually have been wrong. Okay, so it's not really working that way. It does work that way if you take away somebody's immune system. So the people who become very, very immunosuppressed, just like severely immunodeficient mice, this is the pathophysiology. Okay, they basically have no immune control. But so if you look at the Burkitt cells, there's actually no EBV genes expressed in them. So this is really now a puzzle as to why the virus seems to be causing this cancer. So, like I said, Burkitt lymphoma cells don't express all the EBV genes that drive the proliferation of those cells. And so what we think happens is that the reason that EBV is involved in Burkitt's is multifactorial. But one of the things that EBV does is that to get into the memory B cell compartment, to survive in you and me, it actually rescues B cells from dying. So without going into the molecular details of how it does that, it actually is a survival agent for B cells. So that's its strategy for persisting. We're all going to die with our EBV asymptomatically, but that's because it's in our memory B cells. And it gets in there, and it keeps those memory B cells from dying, even if they haven't encountered antigen as they go through development. So the fact that it can do this, we think, rescues a lot of cells that have undergone chromosomal translocations that should have died. Okay, and so it basically rescues a lot of potential Burkitt precursors. Now, why is it that we don't have Burkitt precursors, and why don't we get Burkitts? Okay, and the answer probably has to do with the malaria infection. Okay, so it's unlikely to be due to just the immunosuppression. If you have constant malaria, you are immunosuppressed. But it's not just the immunosuppression, because, like I said, there's a lot of people with immunosuppression, especially, even people with HIV in this country can be quite immunosuppressed chronically, but they do get Burkitt's at a higher rate, but not the same kind and not the EBV positive kind. So there's a couple of other reasons. In addition to the immunosuppression, it may increase the EBV load, but again, that doesn't explain what is it about EBV and malaria, okay? One answer, which probably plays a big role in it, is when you're a kid, you've been infected with malaria over and over and over in Africa in some of these areas. You just are never really free of malaria and other infections, parasitic infections. So what's happening is that when you're, 4 years old, your immune system has had the throttle put to the accelerator put to the floor constantly since birth. Okay, so what that means is that your B cells are constantly encountering antigen, and when B cells are encountering antigen and going through that developmental process, they're actually undergoing chromosomal translocations. That's how we generate antibody diversity. Okay, so that's a normal process. But what happens in these kids is that they now get hit with EBV infection at the same time that this tremendous revving up of their immune system is going on. I mean, their spleens are all this big. No, seriously. Okay, if you go and do physical exams on these areas where malaria is endemic, they've all got hypersplenic pathology. So this is one of the things that we think is going on, is that this perfect storm of chronic infection, malaria, immunosuppression, and EBV infection, which occurs, like I told you, at an early age in the majority of people. So the key is going to be, if and when malaria is eradicated, does the incidence of Burkitt go down? And does it disappear? So one of the benefits of improving public health in these countries is potentially to almost eradicate these terrible childhood malignancies, just like we've essentially eradicated varicella zoster here. So EBV is also associated with Hodgkin's. I'm not going to go into all this. There's stuff I could talk to you about for a long time, but I'm going to talk briefly. This is an epithelial lesion that we don't see very often nowadays, but we used to see a lot in people with HIV and AIDS, and it's called oral hairy leukoplakia. And it's really, this is not infectious per se, it's the epithelial cells proliferating under the influence of EBV. And like I told you, EBV infects epithelial cells as well as B cells. And so you can get tumors not only of the lymphoid system, like Burkitt's lymphoma, but also nasopharyngeal carcinoma, which is a epithelial carcinoma of the nasopharynx. And it has a very remarkable geographic localization, and it's commonest in southern China, where I think the incidence in of Burkitt in Africa is high, especially in some places like Uganda. It is the most common childhood cancer, but it's you're talking about a few per 100,000. In some parts of China, it's as high as 50 per 100,000, where it is the most common cancer, period, especially in males. Okay, and why is that? And again, these all have to do with public health, maybe. Some of it with genetics, okay, because there are genetically sort of homogeneous or predominant populations in some of these areas. But salted fish, which has all kinds of God knows what chemicals in it, including nitrites and other things. But there's also indigenous medications that everybody takes. So there's a lot of chemicals in these things that can actually have effects on the virus replication. It can have effects on immunity. And I'm not going to show you any pictures of nasopharyngeal carcinoma, which, as you can imagine, can be pretty bad. But this is another area where the Chinese government is very, very invested in having a vaccine to EBV in the hope of preventing this. But there are all kinds of potential complexities there. But they're pushing ahead, and they're trying some vaccines in those areas. Now, the other thing that I'm going to mention briefly is Kaposi sarcoma-associated herpes virus. And KSHV was really discovered because of its association with an aggressive form of Kaposi sarcoma early in the AIDS epidemic in the 80s. And, you know, this has been known since the 1800s, but it was an indolent, it was almost like skin cancer. It affected elderly, again, had a male predominance in the Mediterranean, and a lot of people died with it rather than from it. And it was described by Moritz Kaposi in the 1800s. And there was actually an endemic form of this in Africa prior to the HIV epidemic, which resembled classic KS, but it was actually more severe, and we didn't really know much about it because we didn't know much about Africa, and we didn't really care, and we didn't know what went on over there. But, you know, the European pathologists who were writing their classic textbooks really didn't write a lot about this. But this was definitely in Africa all along. And then the epidemic form of KS, which is much more aggressive and HIV-associated, has severe involvement. And this is what's happening in Africa now, superimposed in an area of very high seroprevalence. It's essentially disappeared in the United States because of highly active antiretroviral therapy, and also because it's spread as you know, probably through saliva from person to person. And because HIV transmission has been sort of decreased and HIV has been treated, people are not spreading it in this country. So it probably also occurs via saliva. And, you know, the seroprevalence is less than 5% in this country, except maybe in certain high-risk groups. In Mediterranean countries and the Caribbean, in like southern Italy, for example, it's quite high. It's like 20%, to the point where it's a problem in organ transplantation. Okay? But in Africa, especially, again, it's somewhat geographically dependent, but the prevalence is very, very high. And so the remarkable increase of the incidence of Kaposi sarcoma in Africa is due to this combination of factors again. And, you know, I think depending on how things go, this could also be a really bad problem, just like, you know, TB has been. And so this is just a picture of the sort of virulent form of KS that you can get in the setting of HIV. So this just reiterates what the mechanism is of why these viruses, which we all have, or at least with EBV that we all have, can lead to cancer. And I just thought it would be interesting to sort of bring together these how, you know, vaccination, socioeconomic conditions, geographic conditions, climate, and infectious agents all interact to cause public health problems.